Oh yeah, so it's it was this big study. Oh, I'm not an expert on it, but it's this big study by the people who did Decades of Disparity. Do you remember that publication? That was kind of a publication by the Ministry of Health in the early 2000s, which was the first to really look at those ethnic differences in mortality. And so this is downloadable online. I just Googled it. And this is just showing death rates from cardiovascular disease between 1980 and 2010. So does anyone want to tell me what they can see from this graph? Good news thing?
It's been decreasing.
It's been decreasing, yeah, it's declining, cardiovascular. There's a massive decline actually. I mean, look at the pink line over here, the massive decline in mortality. And what's, out of all the cardiovascular diseases, what's the biggest one? Yeah, so it's ischemic heart disease. So my research group looked in a bit more detail about mortality of ischemic heart disease. And this graph here, these graphs show coronary disease mortality rates over the last 10 years or so in men and women by ethnicity. So Māori in red, Pacific in blue, Indian in green, and Europeans in black. And then over here, the non-Indian Asians have very low ischemic heart disease mortality rates. So is it because they exercise more? Well, actually, I don't know. I mean, it would be interesting to see, because I don't think in the physical activity surveys, I don't actually think Asian people exercise well. Actually, Pacific people have quite high rates of physical activity, especially Pacific children.
Or they say so.
Well, yeah. So, can anyone tell me something from these graphs? Just yell it out. Who's got the highest mortality rates? Māori and Pacific. Yeah. So the confidence intervals, which are those thin lines up and down, they're showing you kind of the 95% range. So Māori and Pacific very similar. And just a massive gap. Like Māori and Pacific people have ischemic heart disease mortality rates that are twice as high as Europeans. That's really significant.
But then, I was looking at the women, and what happened?
Yeah, what happened?
It went down, and it suddenly shoot up.
Yeah.
From 13 to 14, 15, so stuff was happening.
Yeah. No, you're right. And what is happening there? We're not sure. So it'd be good to do even more recently to see what's happening. Has it gone down again? Is it increasing? So then we kind of just calculated how quickly the rates were declining. Yeah, so that's a really good question. So my research group has really kind of grappled with that stuff because in 2008, have you guys heard of PREDICT? It's a cardiovascular risk assessment tool in primary care that looks at the different risk factors for cardiovascular disease like smoking, blood pressure, and cholesterol. And we did an analysis looking at the different cardiovascular risk factors by different ethnic groups. And we found that most of the Pacific groups were very similar to each other, except Fijians. And actually Fijians had cardiovascular rates, risk profiles that were quite similar to Indians. And so what we thought was that actually if you use national data, a lot of the Fijian Indians are ticking both boxes, so they're ticking that they're Fijian and they're Indian. So what we do in our analyses, usually what you do is you use this prioritisation process. So if someone says they're Māori and something else, so you, for example, would be Māori in the national data sets because they always prioritise Māori. If someone is Pacific and something else, they're Pacific. And then if they're Asian and something else, they're Asian. So what usually happens is that Fijian Indians, if they tick both, they become Pacific. So we recognise that, so what we did was we ended up not counting them because it was too confusing. But then after I'd published the paper, someone from the Ministry of Health rang me and said, actually we're wondering if one of the PHOs is purposely ticking Pacific because, you know, at the time there was you get more funding if you've got a higher Pacific population. So what we do now is we look at all the ethnic groups. If someone says that they're Fijian, we also look, and if they also say they're Indian, we actually classify them as Indian. That's what we do in our research. So that's a really, really good question. I'm not sure what other groups do, so you do have to be wary of that. Because it's unfair, it kind of, dilutes the stats.
Don't they, patients tick what they are first, as first ethnicity, so you don't take that necessarily.
Yeah, so it's so ethnicity is it's a self-reporting thing, so people can obviously just choose what they identify with. For the purposes of health data sets, it doesn't matter whether you choose Pacific first or last. If you're not Māori and you choose Pacific, then you're going to be in the Pacific. Even if, for example, you you identify more with, say, Asian or something else. In the data sets, they do that prioritisation process, which has got its pros and cons.
Is there different stats to the stats that you get census?
Yes, so that's a really good point. So Statistics New Zealand they don't really like the prioritisation process. Why do you think health uses prioritisation?
So they're trying to get to the truth, rather than saying something that is
Equates money.
Yes. So
justify the
So the first thing is that they really want a denominator, like you want your population to add up to 100%. Because if you were to include every single group, so for example, I would tick European and Samoan. So if they put me in both groups, then the whole population would be more than 100%. And the reason they do prioritisation is to try and make sure that they don't overwhelm the smaller groups by putting everyone in the bigger group. But Stats New Zealand, what they do is they do combination and total. So if they can do like people who are Pacific and European or Pacific and Māori, and they also do a thing which is total response. So if you're Pacific, you put in Pacific, but if you're Pacific and European, they put you in both. But then that way, the denominators add up to 100%, add up to more than 100%. So these graphs, we just looked at how quickly the coronary disease death rates were declining in everybody, and it was about 5% per year in all exit groups. But for Pacific men, it was lower. It was declining at about 3% per year, and for Pacific women, even lower, so only 1% per year. So we looked at deaths, and we also wanted to look at who was being hospitalised with the disease. So this is, over here you've got the graph of deaths in men, and here are the hospitalisations in men. So do you want to have a look at that and tell me what you see? So who had the highest death rates from coronary disease? Māori men? Māori Pacific men? Who's got the highest hospitalisation rates? Indians. Right. So we thought that was kind of weird because you'd think the people with the highest death rates would also have the highest hospitalisation rates, right? So what we did was we calculated like a ratio of how many people were hospitalised for every person that dies from coronary disease. Does that make sense? So we got the rates, and then we divided the hospitalisation rates by the death rates.
Is it, from looking at the graph, is it because the Indians were more acceptable being in the hospital rather than our people that even thought they know they're unwell, but there's sometimes just admitting and then too severe at that time, and then count as that rather than hospitalization.
Yeah, and so this
The pain threshold.
could be.
Well, the second one looks like it's a response to treatment regime.
Could be.
So, because the longer line is now above 4, and it depends on how much it is.
So those are all really good ideas. Let me show you the ratio. So for Asian and Indian men, about 7 or 8 people were hospitalised with coronary disease for every 1 person that died.
So they have sick first.
So for Europeans, that ratio is about 5. So 5 European men hospitalised for every person that dies. But for Māori and Pacific men, what do you think the ratio is going to be? Okay, so the ratio is around 3 or 4. So fewer men hospitalised for everyone that dies. And this is why it's really important for us to get a handle on data, because we need to be able to interpret the data, not have other people interpret the data for us. So all those reasons that you said, not seeking help, having a higher pain threshold, not recognising the importance of the symptoms, or not being able to access care in a timely fashion. We've done research that has shown that Māori and Pacific people are less likely to call an ambulance. Now, for those of you in Wellington, it's kind of weird because the ambulance is free, but in Auckland, it's like $80 or $100, and that's a real barrier to care. That's significant. So we did the same thing for women, very similar. So same ratio, Pacific and Māori women. Indians much more likely to be hospitalised. And I've talked to my Indian colleagues, and they say, Indians are very, they really value, healthcare. They want to get the best of everything, so they're really proactive in seeking care. Really?
They complain about everything. They have a visitation in a group. They complain for the whole village will come and visit the one patient.
There's actually a research review article that I was just telling Fuimono, and it compares pain thresholds in different ethnic groups. I'll send it to you guys so you can see. And it had, the Europeans had the lowest level of complaint, I think, and it had Indians had the highest level of complaints, but Pacific had the most hysterical responses. Hands up who was in the research.
But behind this data, there is a story, and it's really important that we're able to tell that story. And so very recently, I've got a student at the university looking at some stroke stuff for us, and she's looked at stroke incidence in younger people. And this graph here shows stroke trends between 2005 and 2016. And this really worries me, because not only is there a gap, what do you see is happening to stroke? Yeah, it's not coming down the way cardiovascular disease is. It's going up, if anything. And our young people, these are people of working age. These are people who are in the prime of their lives. And here's another one. So we talked about how important diabetes was. This graph here shows the proportion of people with diabetes at various age groups. Okay, so I've tried to keep Pacific in blue and mine in red. So what can you tell me about diabetes prevalence among Pacific people? Yeah, this is an Auckland DHB, but it's very similar nationally. Yeah, it's got look at this. So if you look, 50%, by around 60 years old, half of Pacific people have diabetes. You know, this is a crisis. This is really important, and this is contributing to our inequities.
You know, it reminds me about the DVD that we watched about the Samoan when they scored liver disease, and the data is definitely showing.
Yeah. So, you know, when people are making diabetes plans and stuff, who are the people they should be focusing on? Pacific people. And this graph is just another graph showing diabetes in young people. And so this is in 2006 and this is in 2013. And as you can see, it was highest in Pacific people, but also the jump was biggest in Pacific people. This is something that we really need to focus on. So, cancer. So, as Gina said, I'm on the bowel cancer working group for the northern region. And this graph shows total cancer deaths between 2001 and 2015. And here's Pacific. We're between Māori and the European group. And then here's the cancer deaths by DHB. The dotted lines are Pacific people, and the solid lines are non-Māori, non-Pacific. So as you can see, there's a real gap here for cancer as well. So the leading causes of cancer inequities for Pacific people in men, it's lung cancer, liver cancer, stomach cancer, and oral cancers. Why do you think lung cancer might be a source of smoking? Yeah, huge. Pacific men in particular have high rates of smoking. And for women, it's uterine, breast and stomach. And obesity is a really significant risk factor for uterine cancer. And stomach cancer is also a leading cause of inequities. Has anyone heard of H. pylori? Yeah. Yeah. So that's something that actually we could treat, isn't it? So it's not inevitable that we get stomach cancer. That's H. pylori is a bug that sits in your stomach. It's more common in people who live in crowded households, but you can actually treat it with 2 antibiotics and a steroid. So yeah, I was asked to write the bowel screening equity plan for the northern region. So I'm just using this as an example. This is the bowel cancer registration rates for the northern region. And at last we've got some good news. What's the good news? So we're not the top. Yeah. So Europeans have the highest rates of bowel cancer registrations, followed by Māori and the Pacific. So this is bowel cancer registration rates.
So is that because it's low, because not many people go, or is it because it's unconfirmed?
So these are all the people with confirmed bowel cancer. You're right. That's a very good point. Take a look at this. This is bowel cancer death rates. What do you see here? So, yeah. Yes, that's right. Yes. So that's a good point. It's going up. But also, we didn't have the highest bowel cancer registration rates. But we have death rates just as high as Europeans. So, oh yeah, so why don't you tell me, like... Do you think it's because they don't go?
I think, it's all,
They wait until it's been.
it's, yeah.
That could,
There's,
yeah, that could.
I don't know if it's cultural or it's just that we're, you know, growing up and also the athletes, it's all private.
Yeah.
It's you alone, unless, you know, and then, even me, I mean, to tell the truth. It's very hard for me to, you know, that, so, and in order for you to go and something private, it's very personal. And maybe some of them just can handle the pain until it's getting out of hand, they can't and then they don't want to talk about it.
What do you guys think about that? What else do you think might be some of the reasons?
The cost.
The cost, yeah. So embarrassment, cost, cultural things. Anything else? It's both, yeah.
Asymptomatic.
Could be, yeah. Might be. Do you think there's genetics that make us have a more severe form of bowel cancer?
Yeah, so the DNA is
Is this the first study focused on
bowel cancer?
Yeah, was there any more before? But that's the thing, it's very
There
hard
was.
to say genetics. It's how when there was no
What's your baseline?
Yeah.
prior, you know, colonization, also with, I don't know if it's all with the diet and all lifestyle.
Yeah, and diet is a risk factor for sure. Like studies have shown that if you eat more red meat. Gina, do you have any thoughts?
Can it be like, are we talking about the difference or the?
So both. Like, why would we have lower registration rates but higher death rates?
The lower registration rates might be because when we were sending out the bowel kits, they found that specific people found that it was kind of like what you said, like when you could do the bowel kit, it's kind of like private. So they felt that they didn't know how to do it as well, plus it was like kind of tougher doing it like in your own space. Also, they didn't register because of that, but it's different with the death rates because of what they didn't do before.
And so that's why it's really important to have lots of Pacific workers who are able to understand the cultural practices and that kind of thing. So what they did is there was this huge study called the Piper study, which is really looking in depth at everything, all the bowel cancer registrations over a certain time period in 2007, and they followed them up and they looked at what had happened to these people. And what they found was that survival rates were lowest in Māori and Pacific people. And you're right, Pacific people were more likely to first present with their bowel cancer in ED as an emergency. And Māori Pacific people were also more likely to have their cancer have already be spread throughout their body. So I guess that's one way of looking at it, is that Pacific people present late. But but stuff that we've heard in the community is that people say, but I did present to my GP several times, and he said, no, it was fine. And then it was only until I went to hospital that they diagnosed it. So it could also be a thing about accessing primary care and accessing good quality primary care. So it's really important to understand the data and what might be happening behind it so that we can do something about it.
Just a thought. Sometimes they can also be missed in clinics during follow-up, so it can be the clinician or the facility that they go to, because I find that happens to gynae. Sometimes I find surgeons say, oh, we were supposed to do her on so and so time, but somehow she got missed. So somewhere along the line, this may have been presented, but then they've been dropped for some reason, or they have some cancellation along the way during clinics, and then at advanced.
that's the onus on the health system, isn't it? That's the health system to make sure that we follow these people up and make sure that we complete their treatment.
I think it's also the other thing too is that even though maybe they present it themselves, but it's also the understanding of the importance of, to follow up the patient themselves, because that, conversation, and then if the doctor or whoever, emphasize the importance and literacy, understanding of the implication, and then they just go and then no understanding, and then that's it.
And I mean, I think that's a really good point, because we've got a Pacific cancer nurse at Waitemata, and she tells us so many stories about how there's this kind of miscommunication between non-Pacific clinicians and Pacific patients. So one of the stories she told me was that the doctor went in and said to the family, your mother's palliative now, we're going to take her to palliative care, we're going to take her to hospice, we're going to keep her comfortable, blah, 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 blah. And then he left, and the nurse came in, and they were like, oh, right, well, we're going back to Wellington now. She's like, why? She's like, oh, the doctor said she's fine, she's comfortable. He had never actually said, your mum is dying. So, there's what the clinician thinks he's told the family is not necessarily what the family's heard. And so it's really important to ensure that, our patients understand what's happening. The onus is on us, it's not on them. We can't assume that, and often, there's other stories where oncologists will say, oh, you've got a tumour, you've got a growth, you've got this and that, but they never actually say that a person has cancer. So the person doesn't understand that it's really important to get your treatment. This is really serious illness.
Sorry, this might need to also, if they ask a question and they get that kind of look like, oh, I can understand it.
Yes.
They're not going to go back a second time for that.
Yeah, that's right.
Corina, one of the things we picked up was in community meetings when we did the Pacific primary research, was conversations around the attitudes of some of the services. And I recall the Samoan woman that went to take the mother to the GP. But it was actually the most important was the receptionist.
Yes.
It was her attitude. She took a look at her and she said, she looked me up and down, and then she said, wait. And it was just quite a thing for me. And I said, in Samoan we were laughing about it. She said, I could stop it because she thought that I was here for my weight. But but what she said was, but the common thing was the non-verbals. People don't want to because, I have been on the other side, you dress like this, and the reception look at you, and if you're in the reception, they don't know whether you speak English or anything like that. It's actually quite interesting discipline. It's actually before you get to the clinician, it's his own barriers that you have to go through that. The receptionist, people just walk out.
And, the receptionist is the front line. They're the first person, and they often act as gatekeepers.
Yeah. And I just wanted to add our thinking from yesterday about Karina's statement that the onus is on us as the health provider, because what is it that makes the onus on the health provider to provide the service that meets the patient's needs? It's a health and disability right. It is your right as a patient, as a consumer, to get the care that you need in the language that you understand. So what we have to be careful about, because we get colonized by the idea that the problem is with the patient, and we hear this kind of language all the time that they don't understand, they don't care about their health, the health and disability legislation, the Bill of Rights is very clear that the onus is on the health professional and the health system to do this. And this is part of what we need to change, because you hear all of our discussion is all about, but it's the patient's fault. It's our own fault because we've internalized some of this. And sometimes it is our fault. But actually, what we're trying to do with health services research is to change that lens a bit, because if you talk to the patients and the families, you will hear quite a different story about how their names are mispronounced, how they waited for hours and nobody called them, how they had to drive around the car park for 3 hours because there was no car park. And so we have to rebalance that view of the health system that it's all their fault. Because we provide a service, they should just come.
That's right, and that's why I think it's really important for all of us to just get a handle on the data, because data can be used against us as well. Like people can say, oh, look at those high DNA rates. Specific people just don't want to come to clinic. Well, actually, is it because the health service is just not responding appropriately to their needs? Yep.
Patients, particularly they get really annoyed because the clinicians say, oh, patient is not too enough here. And when they finally get referred to the service and provide transport, they say they're really angry at the clinicians because it wasn't that they didn't want to go, it's just they had nobody to give them a ride or help them to get there. And these are lots of the things that we've seen in the county, some of the things that we've seen anyway.
Yeah, and it's about people understanding what's going on in people's lives. Like, it's so much easier for someone with a car and with a job with flexible hours just to shoot out to an outpatient appointment. They can pay for parking, but actually for someone who, say, works a factory job where they have to clock in and out, that's a big deal to have to take time off to go to an outpatient clinic. And if you go there and you've paid a lot for parking and then you sit there for 3 hours and then you're seen for 5 minutes, you don't see the value in that. So you might not come again.
And since when my cousin has cerebral hemorrhage, and so they took him to the hospital and said, I'm sorry, you can't do anything for him. He's only really young, he was only 45. And so the family said, well, we want a second opinion. It took him to another DH when he got treatment and he's alive. So they wouldn't just left him, they took him at what he looked like. He, Pacific man, drank a little bit, didn't really smoke, but they didn't really make any efforts to kind of do regular investigations, which to me is shocking. He was here in Auckland. And if the family had got around and said, no, we're not happy with this diagnosis, we want another opinion, he would be dead. They would have just left him to die.
Terrible story.
It's shocking.
Yeah, and I don't say anything about it in these presentations, but people are really starting to talk about unconscious bias and institutional racism and that kind of thing.
So I work on the board, and we have sort of this his cousin. We have millions of patients that sit on our wall for a while just waiting for acceptance. And we wonder, is it because they're moldy? They take up a acute bed just waiting for an angiogram or some complication or something. We wonder, maybe they're taking the European patients and every day they come back with an excuse not to take our patient for this procedure. So, yeah, institutionalized racism.
So sometimes there's some attitudes of, I spoke to a colleague of mine and he feels that it's because we don't complain. We're very, very humble and we wait patiently and because we don't know our rights, some of us, patients in particular, we're very happy to wait there, just hang around.
So with our researcher hats on, we're going to ask Karina, what is the evidence for some of these things?
So, yeah. Thanks, Debbie.
Because we're learning to say because.
Yeah. And I think evidence is really important. So I don't have anything about like the waiting times and stuff, but I do know there has been quite a bit of research looking at people's experiences of the health system and how people do say they have different experiences to other people. So one of the researchers that I know, Rachel Brown, did her doctoral thesis interviewing Māori and Pacific families who had a child with cancer, and they interviewed them about their experiences at Starship and Ronald McDonald House. it was just amazing, you know, what they said. So they said they got treated differently. You know, they were eligible for some things, but people never told them. But they found out from other people. They got told that, they talked about being told the child's diagnosis in the corridor. And, you know, the clinician's so busy, they're just, you know, quickly telling them and they rush off, there's no time for questions. And then they have to relay the diagnosis back to the rest of the family. They talked about, you know, there are cultural support services available at those places, but people talked about nurses using them like the police, like if families were being too noisy or they were taking up too much space, they'd call in the cultural support workers to come and tell them to keep the noise down, rather than as a support service. So it created this real tension, and that really affects your healthcare experience and the way you might interact with the health system.
So thank you for that, because I think what we're trying to get to is all of the stuff that you know and these beautiful stories that you share, there is some evidence for it. And so when you're writing your assignments, you're also needing to find this evidence and put it together with your own experience to tell the story. Yeah.
But Toyna, can I just take the point that you were saying some of your class? Now, you know, and we were having a brief discussion with this morning. So I'm saying, we know there's institutional racism. We know that, but how is it going to benefit? And one of the things that will benefit is your class. Rather than say, oh, institutional, for instance, that question that you asked. Okay, the engagement here, but more density here. So for a clinician, how's that? The reason I say that is when I was on the district health account at Capital Coast, we had a virtual cardiology, and it was cardiologists from the Wellington Hospital presenting. And the data he showed, and the data, it was all the data, and it showed that Pacific Island and Māori require more intervention in heart, and we have the whole thing. But the actual intervention was low.
Yes.
Now, luckily, we had Stephen Power because he's a public health physician. But the cardiologist was really kind of angry because he said, what are you implying? I said, I'm not implying anything. I'm just saying, look at your data.
Yeah.
Well, of course I was implying something. Of course there was something dreadfully wrong, the needs there, but the ones who were getting the treatment are Tārangi. And Stephen said, well, actually, and he named it, but he was a Pākehā in the way.
Yeah.
My point is about, yeah, we understand the racism, but at the end of the day, how does this benefit our people? But this, we know that the cardiologists and we know that clinicians are human beings, and they're going to get ready to think if we say, oh, you're racist.
Yeah.
We all know that.
Yeah.
But it's how to use these kind of things as...
That's right, and I think the framing of
Yes.
the issue is really important. So I kind of have had a similar experience where I did some research looking at, you know, people who come to hospital with a heart attack, they get a stent. And what we found was that Māori and Pacific men with a heart attack were actually less likely to get a stent than European people. But if you present that to the cardiologists, they get really, really angry and they say, well, what are you saying? Are you saying that I'm racist? I'm not
Yes.
racist.
That's
Like,
exactly what he
yeah.
said.
But what you need to do is kind of almost like disengage yourself from that, like you're like, well, this is the data, and there might be other reasons behind it too, like, you know, people with certain comorbidities like diabetes or renal failure might need a bit more workup before a stent, but that's, again, the onus is on the health system to make sure that we, you know, we make sure that people have good diabetic control, that they don't go on to have these complications. It comes back to us. So I think when we're framing things and taking it back to clinicians, we need to do it in a, I always try to do it in a constructive way. How can we work together to address this problem? You know, because it's everyone's problem. You know, it's not good for any society to have certain groups of people who experience poorer health outcomes than other people, because it's expensive. You know, and you know, Pacific people, we're younger, so we're of working age, and so if we're healthy, we're contributing taxes, we're productive members of society, so it's actually really important. Pacific health is super, super important. And that's what we need to, that's how we need to frame it for clinicians. Oh yeah, so this is just bowel screening participation. So even though we've got all these issues, Pacific participation in the bowel screening program is significantly less. So that's why people like Dina are really important. And then there's this thing called multi-morbidity. Does anyone know what multi-morbidity is? Does anyone want to guess what multi-morbidity is? Yes. So it's having more than one chronic disease. So probably everyone in this room knows someone with diabetes, with cardiovascular disease, like with a whole bunch of things. What that means is that they often need to have more medications, there's more risk of interactions with those medications. Okay. How are we going for time? How are you guys?
How are you feeling? Everybody, you want to stand up?
We want to hear more of you.
Yeah, there's a question.
Can I just ask a question? What did you find was the reason why people were less, they didn't get the screening?
This bowel screening? Oh.
Yeah, why do you think that was the result of the finding?
Well, you guys should be able to tell me this. Why do you think we've got lower bowel screening participation rates? You guys talked about it before. What's the test? What's the test for bowel screening?
It's the poo test.
It's the poo test, right? So we have to poo. And what do you have to do after you've done it?
Send it to work.
You send it in the mail. Do you think?
I know.
Do you think any Pacific people are going to do that?
No.
I mean,
Anything else apart from that you found in Auckland?
so there are some other things as well. Like all the resources, the promotion resources, they're in English. They have translated some, but apparently, like people have had a look, and the translations are not that good.
The reason why I'm asking is because I'm just working towards having a group of Fijians, group leaders, and the community helps. They have this for the first time. So I want to know what is your success rate in doing this in Auckland, so that if anything we can implement it in the hospital.
So, actually, you have a really engaged Pacific general manager, Tofa. Is it Tofa?
Hutt Valley?
Or was it Talalele?
No, she's at Hawke's
Oh, who's at Hawke's Bay? There is Garcia with Pacific GM. Did they do that? Yeah, they did. Right.
And he's asked me to interpret
Yeah.
on the day or one of the but I'm just thinking this because I don't do bowel screening. I work in Vienna. So I'm wondering if there's anything that Auckland is working on in Auckland for this sort of thing. What is it that I can take home?
To be honest, I think what they've found, and it's really resource intensive, is face-to-face. Having people sit down and explain things, like that's where they've found the most success. And it's really resource intensive, but it's also the most successful thing.
In a group, yeah. So on a Sunday after a church service,
Yeah.
there were 6 cases that were detected after this
Wow.
group meeting. So they're trying to push the other Pacific groups in the hospital. This can happen.
But there's also the power of the community. So people have had, positive experiences with the bowel screening. It'd be really great for them to go out and talk to their communities, because that's who you trust, isn't it? Is your own friends, your own family, and if they've had good experiences and they share it with you, you kind of go, oh well, maybe this is a really important thing to do.
We're going to be down in Christchurch, working with another agency. We're organising someone to come speak about, about bowel cancers and just really, looking at the signs and symptoms and things to do. Just a real simplistic 1-hour session.
And that's great.
Make people aware of.
I think, and using personal stories, like if people can relate it to themselves and think, how might this affect me? I think that's probably the most powerful thing.
My question is that I'm not sure if I believe what age
So bowel screening is in 60 to 74-year-olds. So there is also a bit of, what's the word, discussion. There's some discussions going on at the moment because Māori have asked for the age of bowel screening to be extended for them down to 50. And the reason for that is because Māori and Pacific people get their bowel cancer earlier, so they're younger. So when you look at the graphs, and I should have brought them actually, when you look at the graphs, if you look at people who got their bowel cancer at 60 or above, you would miss about 30% of cancers in Europeans, but you'd actually miss about 60% of cancers in Pacific people, because most people get it before then. So there is a lot of discussion at the moment going on about what we could do.
And also, thinking, especially with our high mortality, with the life expectancy, with the European and yet, as you said, according to that age, most of our
but people are
already passed
the
away.
ways before. Yes,
Yeah.
exactly. Yes, that's right. So if we wait until 60, a lot of people have gone by then. You're right.
The other thing that I think, I was just thinking about when you were talking about it is we've known and reported on the problems with health literacy for 20 years. Why do we still not have the resources? So when we were recently interviewing a GP in South Auckland, a Chinese GP, who's doing a really good job for his patients, and he was showing me how he was making up his own health resources to try and communicate with his patients. And I'm like, so part of the issue is we report all these things, like problems with health literacy, but the health system response doesn't exist. So this is another way of...
You might get someone to translate a document. Someone's telling me it's about $7 or something paragraph. And I'm thinking, oh my goodness, it's just absolutely ridiculous.
It is, but you also have to get the translations checked.
That's why medical evidence,
Yeah, because
It's just like,
I know it is ridiculous, but it's important to get translations. But also, I think often, when we look at data, we go, oh, the solution is education. We just need to educate them a bit more. We just need to give them a bit more information. But do we? We all know that obesity is bad for you, and do we just need to keep telling people obesity is bad, or do we actually need to empower people to, So I've got a slide here. So it's just talking about, I just go on and on and on. It's just about health literacy, and I think that health literacy is actually, when we think about health literacy, we're like, we need to educate people. Actually, health literacy is about the health system. It's about making sure that the health system has presents information in a way that people are able to understand it. And there's the Ministry of Health has released like a health literacy framework that talks about health literacy of the system. But there's been a few studies, and I don't know if some of you know Tua Suka from Wellington. She's yeah, absolutely. She's a nurse. She works at Hutt Valley. But she did her PhD looking at Samoan people's experiences of cardiovascular disease risk assessment. A few years ago, cardiovascular risk assessment was a target, so everyone was doing it, and that GPs would get people to come in, do their risk assessment, go, this is your risk of having a cardiovascular event, give them some medications. So Pacific people had really high cardiovascular risk assessment rates, so we were over 90%. But what Tua found was that people didn't even understand the process. So people would come in, the doctor would say, come in for your heart check. And then people would come in expecting to run on the treadmill and get an ECG. And then they'd get some blood tests and get their blood pressure. And they were like, what is this? This is not a heart check. And then people would talk to them about losing weight, physical activity, and they'd give them these huge booklets, all in English. With Europeans on the front, this doesn't resonate with me at all. I have no idea why I did it. I did it because the doctor told me I did it, but they got nothing out of it. So, we have to be careful what we measure, because if we're measuring, tick, we've done the cardiovascular risk assessment, well, that's fine, but did that make a difference to our patients? Did that make a difference to health outcomes? The other thing is, the study in 2009 by this group looking at antibiotic use among Samoans, found that less than 2% of people knew what antibiotics were for. 60% of people thought that antibiotics were for pain relief. Yeah, so we assume that people know why we're giving them stuff. We actually need to explain to them and help them understand why they're taking these medications. Oh yeah, and of course, Debbie has done some really important work. I think I'll take the hint.
Must be lunchtime. Is there morning tea?
Yeah. No, I'll take the hint. I'll wrap up. I'll give you all these slides, and I'm very happy to talk with everyone, with anyone over the break. And if you've ever got any questions about data, I'm based at Auckland DHB, so I'm very happy for you guys to email me. I just wanted to finish with a couple of slides. So I don't know if you guys saw this. This is quite recent. A couple of weeks ago, I was rung to provide some commentary on a study by Growing Up in New Zealand. So I spent 2 hours on the phone trying to find someone else who would do it for me, because they asked me to be on the camera, but no one would do it. What it is a study by Growing Up in New Zealand. Does everyone know what Growing Up is? So it's a study of about, 3,000 children who were born, I think, in 2009, and they've followed them up over time and measured a whole bunch of stuff, looking at their health and all sorts of things. They did this really interesting study as a genetic study, looking at a particular part of a person's, it's actually 4-year-olds, their genes, called a telomere. Has anyone heard of a telomere? So what a telomere is it's a part of the gene which is associated with your lifespan. So the longer your telomere, the longer your life is supposed to be. And of the 4-year-olds, guess who had the longest telomeres? Pacific people. That's right. Pacific 4-year-olds had the longest telomeres. So what that means is we have this genetic potential to live really long and happy lives. So, people like you are really important, because we need to enable people to live these long and happy lives. Because at the moment, the life expectancy graphs are telling us otherwise. But we do have that genetic potential. So let's use that and make sure that we take a strengths-based approach. I'll finish with this photo. I said to Mum, do you mind if I use a photo of you? And she said, yeah, as long as I look good. She's not quite looking at the camera, but this is my uncle. So these are 3 of her siblings here, and this guy's her cousin. Has anyone seen Three Wise Cousins? Yes. He's the dad. Oh, this is my uncle. This is my mum's cousin here. So this is them at a recent get together. My mum, there were 11 kids in her family, and 6 are still alive. So one died in infancy, another one died when she was 14, she died of an infectious disease, another one died of a massive heart attack at the age of 40, one of my aunties died in her mid-50s of pneumonia, and another one died last year in Samoa in her mid-50s of a stroke. And then recently, my mum's older sister, who's living in Australia, has been diagnosed with stomach cancer. So, even though we've got all this data, and data is really important, there's actual people behind the story, and that's what we need to keep in the centre of our minds, is that, all this data is really good, but at the end of the day, it's our people. It's really important. yeah.
What's name? I know the face.
This one, this is my auntie, Neema.
Oh,
She's very big in the church.
yes, it is.
Yeah, she just came back from church, you can tell. Yeah, she's
Is that your mum's sister?
yeah, that's my mum's sister. So yeah, she's my mum's sister, but she was actually adopted out. So she's her biological sister, adopted out by her mum's sister. So they grew up as cousins, but they're actually, yeah. Yeah. So thank you very much. Thank you for